In the fluid environment of blood plasma, von Willebrand factor monomers constantly assemble into massive, complex glycoprotein chains called multimers. These sprawling structures are essential for capturing platelets at the exact site of vascular injury. But when this assembly process mutates, the resulting bleeding disorders present a severe clinical challenge. Because patients exhibit heavily overlapping bleeding phenotypes, distinguishing a mild protein deficiency from a critical structural defect is nearly impossible through clinical observation alone. This diagnostic flowchart is the modern map for navigating that complexity. Its primary architectural logic is to forcefully divide the initial data. It separates absolute, quantitative shortages of the protein from complex structural or functional defects by applying strict activity to antigen ratios. Relying solely on legacy clinical presentations often leads to misdiagnosis. Accurate classification of these complex variants requires this sequenced, molecularly anchored algorithmic approach. Looking closely at the top two rows of this algorithm, the initial investigations establish our diagnostic baseline. The full blood count immediately screens for thrombocytopenia. A low platelet count here acts as a preliminary flag pointing towards specific qualitative anomalies, like type 2B. Alongside it, a prolonged APTT signals a secondary hemostatic impairment, specifically hinting that factor VIII is failing to stabilize in circulation. Following the logic downward, we identify the type 3 baseline. This is an absolute quantitative failure, strictly defined by a von Willebrand factor antigen level, the total protein present, of less than 1 international unit per deciliter. Contrast this with type 1. Here we see a concordant reduction, meaning both the total antigen and the functional activity of the protein drop, but they do so proportionately. To prove a type 1 diagnosis, we rely on a definitive threshold. The ratio of functional activity to total antigen must remain greater than 0.7. Physiologically, this ratio confirms that the von Willebrand proteins circulating in the plasma, while scarce in sheer number, are structurally intact and fully capable of performing their job. Achieving this ratio greater than 0.7 confirms the core issue is strictly quantitative, safely halting the diagnostic pipeline and sparing the patient from deeper, costly structural assays. The center columns of our flowchart revealed the critical diagnostic pivot point, the discordant ratio, where activity divided by antigen falls below 0.7. This definitively indicates a qualitative type 2 defect, or acquired von Willebrand syndrome. The protein is physically present in the blood, but its functional mechanics are broken. Specifically, we are measuring an impairment at the GPIB binding site via VWF GPIBR or GPIBM assays. Healthy multimers successfully bind to platelet receptors, while the mutated variants simply cannot dock. Because the protein fails to bind, the activity score in the numerator of our ratio drops sharply, while the total antigen in the denominator remains relatively stable. Isolating the type 2N branch introduces a highly specialized set of threshold criteria. Factor VIII coagulant activity falls below 50 international units per deciliter, and the ratio of factor VIII to VWF antigen drops below 0.7. Type 2N represents a precise structural failure. The von Willebrand factor multimer completely loses its binding affinity for factor VIII. It fails to dock, leaving the coagulation factor exposed and unsupported in the bloodstream. Without the protective stabilization of VWF, this exposed factor VIII undergoes rapid proteolytic clearance. The resulting deficiency mimics the exact clinical presentation of mild hemophilia A. The sub-0.7 ratio pivot and the type 2N pathway prove that measuring sheer protein quantity is clinically dangerous when the protein's specific structural binding domains are compromised. This second-tier testing panel outlines how we resolve the exact subvariant of a type 2 diagnosis. The primary fork in the second tier demands we evaluate the physical structure of the protein, categorizing the presentation into abnormal versus normal multimers. The abnormal multimer branch correlates to a physical loss of high molecular weight multimers. Electrophoresis gels of these samples show a distinct absence of the heavy structural bands found in a healthy control. We map this specific loss of high molecular weight bands to either type 2A, caused by defective assembly or heightened cleavage by ADAMTS13, or type 2B. Conversely, the normal multimer branch indicates structural integrity that appears visually intact on a gel, but remains functionally dead at the receptor level. This normal multimer presentation is our primary indicator for type 2M. Moving down the cascade, we isolate a final critical diagnostic challenge, identifying the type 2B variant. Type 2B features a unique gain-of-function pathophysiology. The mutated protein has an enhanced pathological affinity for platelet GPIB receptors, causing it to spontaneously clump with platelets without standard injury triggers, which leads to rapid clearance from the plasma. To confirm this exact hypersensitivity, we use low-dose Ristocetin-Induced Platelet Aggregation, or RIPA, a functional assay that actively exploits this pathological eagerness to bind. Secondary structural assays like Multimer analysis and RIPA are the only biological probes capable of differentiating between a gain-of-function mutation and a loss-of-function mutation. Tracing the complete diagnostic journey on this chart shows how an isolated clinical phenotype is systematically mapped to a definitive category, like the direct path to a type 1 quantitative defect. This stands in sharp contrast to the highly complex, multi-tiered pathway required to track down and isolate a specific structural defect, like type 2B. Yet every pathway in this algorithm ultimately converges on a single terminal step: genetic confirmation. Functional phenotype mapping isolates the mechanics of the bleeding disorder, but those mechanics must ultimately be validated by sequencing the exact VWF or GP1BA genes driving the mutation. Advanced sequencing provides the definitive molecular diagnosis needed to resolve any variants of uncertain significance discovered during the hematological assays. This modern algorithmic pipeline elevates the practice of hematology. It transforms ambiguous bleeding phenotypes from descriptive mysteries into precise, actionable molecular targets.